discussion where you can ask questions of any and all of the panel. So with that, I'm delighted to introduce our first speaker, Sarah Nabukira, who is a research associate and PhD candidate at Makerere University School of Public Health in Uganda. Sarah has worked on family planning, abortion, and infertility projects with a goal to contribute to women achieving their sexual and reproductive health rights through research. She's done extensive work around equity, self-care, and high-impact practices for family planning in Uganda. And she, together with a team from Johns Hopkins University and others from Makerere University, have done work on advancing understanding and measurement of infertility and related fear and stigma in Uganda. So please join me in welcoming Sarah.
Thank you, Lotus, for that wonderful introduction. My presentation is going to be about defining infertility, the varied criteria people in 2 regions of Uganda use to identify themselves or others as infertile. So this is the team. These are the collaborators, as you may see, a group of people from the Johns Hopkins University and others from Makerere University. Yes, so broadly, there has been definitions about infertility with unanimous consensus on what fertility is, but largely due to thank you. So yes, there has been agreement on the general notion of infertility as the inability to have a child. There is less consensus also, although around the specific criteria to define infertility. Across and within disciplines, there has been inconsistency on what infertility should be defined as, how it should be measured, with the implications on the prevalence, risk factors, and any possibility of future fertility. Clinically, people who have not conceived in 12 months of regular and protected sex, that is for heterosexual intercourse, meet the biomedical criteria of infertility. Although other timelines have been used, for example, 24 months has been used sometimes, and 6 months has also been used for those that are 35 years or older. And in contrast, demographers consider infertility to be the absence of a live birth among women in union who have no children and have not been contracepting for 12 months. However, there is a fundamental tension between this myriad of definitions and this definition that seeks to just define infertility on a standard way to just to able measurement, to be able to measure infertility in a standard way with anthropologists. Anthropologists, however, they seek to problematize this universal definition. And while the global community increasingly uses the 12-month definition of infertility to estimate infertility and identify the people in need or the related services, there has been little work conducted to understand how individuals outside of the scientific and academic communities define infertility and how this differs across subpopulations. So understanding what individuals consider infertility or problematic fertility to be, and when they would begin to call themselves or others infertile, is such a significant it's a significant thing to do based on the stigma attached to it. And there is considerable familial and societal pressure to conceive shortly after marriages, given the patrilineal and the bridal price system, where women are expected to give birth as a payback. So failing to meet these societal expectations around infertility can lead to many negative psychosocial, financial, and marital consequences. And these consequences do not rely on the diagnosis of the knowledge of infertility, a medical condition, but a social phenomenon. It is usually a social phenomenon, and only one needs to be perceived as infertile for them to face those consequences. And it is unlikely that those definitions correspond to the 12-month framework. The context defines who is infertile. So while there is very limited understanding of the subjective perceptions of infertility, which are more closely related to associated social consequences, only one quantitative study we are aware of had directly evaluated time-related criteria for identifying infertility among male and female respondents. This was in northern Nigeria, and it indicated that 18% of the respondents would define a couple as infertile if they failed to give birth in 1 year of marriage. 32% said in 5 years. 24% said in 2 years, and 12 were pushing the delay to over 10 years. However, this study implicitly only addressed primary infertility and did not evaluate the 9-time bound of 12 months, because not everywhere that infertility is defined based on the time of 12 months. There are factors like relational and other factors that individuals may use to identify themselves or others as infertile or having problematic fertility. So few and more often old studies have focused on locally defined fertility problems in Africa, and these findings demonstrate a wide variability of what may be considered infertility or problematic fertility in different parts of the region, with examples, as you may see. So there is a significant gap in the literature, and existing research has not sought to examine how infertility problems may be defined differently by different subpopulations. We are still using the time-bound 12 months criteria. So the primary concern in many contexts may be childlessness rather than infertility per se, because parenthood is defined as a feature of adulthood and respect. So there is limited evidence assessing perceptions of secondary infertility as well. And existing literature only focuses most exclusively on women. Women and their experiences with infertility or problematic fertility at the expense of understanding how social constructions of infertility may differ for men. Though research suggests that experiences of infertility are highly gendered, there is also little to no systematic assessment of potential non-related criteria used to identify infertility. We have not interrogated how people view the widely used 12-month time definition of infertility. So this study, we wanted to address these literature gaps, and we aimed to explore how men and women in 2 districts of Uganda defined infertility and the criteria they used to identify infertility, examining differences by fertility type, that is primary versus secondary, and gender, male and female. They're not moving over. Oh. Here. So that was the study objective. I'm right there. That was the study objective. So we aimed to explore how men and women in 2 districts of Uganda defined infertility, which criteria they used to identify themselves as infertile, by examining the differences by fertility type, primary or secondary, and by gender. And in Uganda, we have a total fertility rate of 4.6, 15% experiencing a 12 months infertility based on the criteria of 12 months. 46% have fewer children than desired at the end of their reproductive lives, with considerable stigma. Women without children are perceived as only eating or filling the toilets. So I'm going to take you through the methodology for this study. The study design, we used in-depth interviews and focus group discussions, developed semi-structured guides translated into Luganda and Lusoga. Those were the primary languages in the regions where the data was collected. We considered respondents from districts, that is Mokono urban, and Iganga, which is rural. So we wanted to see the regional residence variations. We considered female, aged 15 to 49, male 18 to 54, and they were purposively sampled based on parity, residence, that is rural urban, and if they've ever experienced infertility, but as well as gender. Study recruitment, women primarily were from recent population-based survey, the PMA data. There were women who were recruited from the communities, and we recruited them using VHTs. So analysis was thematic analysis. We used the YINS 5 phases, as you may see on my right. It was an iterative process built coming up with a code book, which was having inductive and deductive codes. And we also used memoing and frequent meetings to discuss and organize and interpret the findings. So some of the findings, those were the characteristics of the participants. As you may see, in total, we had 108 individuals, 53 were women and 55 were men, coming from IDIs and FGDs. The majority were 15 to 24 years. They were married or cohabiting, had at least secondary education, had children, little or half of them participants had experienced clinical infertility. Okay. So we had themes, we came up with themes. The results suggested that Uganda participants' understanding and definitions of infertility are more complex and contextually dependent than biomedical criteria. We identified 3 themes regarding the ways in which participants identified infertility, the perception of infertility as a primary permanent trait and cannot be treated, the varying roles of temporality in identifying infertility, and the relational or circumstantial criteria used to identify infertility. So results per theme, this is one, infertility as a permanent condition, and the paradox of secondary infertility. So many participants agreed that infertility was permanent and it couldn't be treated. And for them, it meant barrenness. An infertile person cannot give birth. That is what they thought. And that brings in a paradox with secondary infertility because they didn't think that secondary infertility was infertility. One had a child and the other had failed to have, so was permanently infertile. That was it. Then they deferred, some of them deferred to medical diagnosis of infertility, that one had to be infertile if they had medically been declared infertile. And so they had to rely on the medical definition of infertility. Then there was variability in time required to identify fertility-related issues. There was variability because people believed that it depended on the goal a couple had. If their goal was to have a child in 6 months, failing to have a child in 6 months would be described as infertility. Failing to have a child in 3 months. So for them, it was what the goal was in having a child that defined infertility. And then there were sorry, there were abstract, sorry, I think I've gone so fast, this and that. Yes, there were abstract definition of what infertility should be, and a wide variability of time relation. Of course, this speaks to also time. It was about time, how much time they had spent in the relationship, how much they had been together, and that could also be used to define infertility. Then there was also abstract relations. If a woman had been in a relationship before and they had had a child in that relationship, they were not infertile. And if they had been in a relationship and failed to have a child and moved into the next and had a child, they were not infertile. So infertility was based on relations. Then lastly, there was also infertility based on if a man or woman was the one infertile. So this was that other other sexual relationships brought the infertility, and other issues of the family, including if a man comes from a family where they don't give birth as much, or they have a history of abortion. For a woman, it was so sexual, previous sexual experiences within the couple. To summarize, this study, I'm going to skip that in the interest of time. It has strengths. I'm just going to take you through the strengths. This study has many strengths. To our knowledge, this was among the first studies to directly examine people's understanding of infertility in contrast to the biomedical definition across subgroups. We wanted to see how the different subgroups defined infertility. The study recruited participants from the community opposed to going to the facilities for only those who were seeking care. We purposively sampled a diverse sample that had an experience of infertility, but also the fact that we had different subgroups of parity, of gender, of rural, urban, of all those characteristics gives us a good contextual understanding of infertility. One of the limitations that the study has is that limited generalizability. We used a small sample, so it may not be representative of the whole Uganda, but also the fact that we used infertility and problematic fertility to capture broader issues. Our data collectors may have somehow used the terms interchangeably, but also we believe that we used experienced data collectors. What are the implications? This work describes the nuances of fertility as a socially constructed phenomenon in Uganda, specifically examining differences by subgroups and interrogating people's subjective perspectives in relation to the medical definition. Findings have an implication for how we can conduct research and develop public health policies and programs to reduce infertility and its associated negative repercussions. Infertility statuses are inherently ambiguous with no criterion to demarcate infertility from not, and including the medical definition. There is no time bound for contexts. Different contexts have different time frames. So efforts to understand the experience of infertility must be aware of the varied community and individual perceptions of this phenomenon and the difficulties conceiving more broadly. This work was published in the Journal of Science and Social Science and Medicine, and you can read this paper for more information. Thank you so much.
Thank you, Sarah. Can we get the third presentation? Does anyone have an absolutely burning question? Can we move on? I'd love to hold most of the questions till the end. I don't see hands. So I'm going to go ahead and introduce Erica Sedlander, who's an assistant professor in the Department of Social and Behavioral Sciences at the University of California, San Francisco. Erica uses mixed methods to examine pathways to help women reach their reproductive goals. and she's currently conducting research in Kenya, Tanzania, and the US to inform interventions to raise awareness around the causes and prevention of infertility. So please join me in welcoming Erica.
Raise this a bit. Good afternoon, everyone. I'm happy to be here with you and to share this research I've been working on. I'm passionate about helping women reach their reproductive goals, and I hope to do that through this infertility work. So thanks for being here. So the infertility is complicated, but today I'm going to talk to you about one behavior, and that's the behavior of seeking care for infertility. And so when I say seeking care, I mean the initial moment where people understand they're having a problem and they go to seek medical advice. That could be from their primary care doctor or it could be from an infertility specialist. But the behavior I'm interested in here is seeking intentions to, and then ultimately seeking care, medical care for infertility. So that's what we'll be talking about today. So you're all reproductive researchers or practitioners, and you're probably familiar with the reproductive justice framework, but raise your hand if you think you could recite and say all three tenets if asked on the spot. It's pretty good. So I'll tell them to you now. The first is the one we'll focus on today, which is the right to have a child. I should look over here, which is the right to have a child. The second is the right not to have a child. And the third is the right to parent in a safe environment. So most of us in our sexual and reproductive health field, and especially at ICFP, we're focused on the right not to have a child. Very important. Today in this panel, we're focused on the first right, which is the right to have a child. And arguably a very neglected part of the reproductive justice framework that deserves more attention. So Lotus already told us about the causes of infertility, but some of the most common causes in sub-Saharan Africa are preventable and treatable. So STIs like chlamydia and gonorrhea can lead to pelvic inflammatory disease, causing infertility. So an understanding of this and what causes it could help to women and couples to seek care. And as Lotus already mentioned, both male and female factors contribute equally to infertility. But as most of you probably know, and Sarah's already said a bit, is that infertility has dire consequences in sub-Saharan Africa. But they're not equal consequences. Women bear the brunt of infertility consequences. There's been a lot of qualitative research on this over the years, but I'm just using quotes from this qualitative study that we conducted recently in Tanzania, the one I'm presenting on today, and women reported that if they or someone in their community were infertile, they would be sent back home, harassed, raped, divorced, or their in-laws would withhold food from them because part of the marital contract is to have children. And so if they weren't holding that up after they'd paid the bride price, they would be kicked out or not given food. So I highlight these because I also want to share that what brought me to this field was that the belief that contraceptives cause infertility was a barrier to contraceptive use. But we heard so much about this barrier and these consequences for women that I wanted to change course and focus on this focus on this outcome of infertility, since it seemed to trump unintended pregnancy in the women we were speaking to. So this is just to kind of highlight and illuminate these consequences to hope get you on board to focus on this important topic. So infertility is complicated, but one of the problems is just limited care seeking. So when women or couples are experiencing infertility, they often don't seek care. So 85% of causes can be diagnosed in the initial workup. So the initial workup is hormone blood tests that give you hormonal information, imaging of your ovaries or fallopian tubes, or semen analysis. And these are lower cost tests than you might think, but only 51%, so only half of couples in low resource settings seek any care. That means initial medical advice for experiencing infertility. So they're essentially suffering in silence and experiencing all those consequences that I just went over. There's a limited research on infertility care seeking, on the behavior of actually going to your medical provider. And so that's what this research is about. Our research question is, which factors affect intentions to seek medical care for infertility in Lake Zone, Tanzania? So it's a qualitative study. We conducted focus groups with men and women of reproductive age and in-depth interviews with medical providers with reproductive health expertise. These were nurses and midwives, gynecologists, and general physicians. We conducted the study in 2 different sites, one rural and one urban. Mwanza is the 2nd biggest city in Tanzania after Dar es Salaam. And for our analysis, we used the integrated behavioral model to really map intentions to seek care, thematic analysis, and matrix analysis to map the themes onto the integrated behavioral model. So I won't go into all the demographics. There's a lot, but for the interest of time, I'll just highlight 3 from the men and women in our study that are related to our research question, mostly related to our research question. So 82% had at least 1 child. 16% that said they had tested positive for an STI in the past, and 26% had experienced infertility or difficulty getting pregnant. So it's a little bit higher than the 1 in 6 that we just heard about earlier today. Although we used difficulty getting pregnant and not a 12-month mark. These were the questions that you had experienced infertility or difficulty getting pregnant. And so now I'll share our results. What about the drivers and barriers that affect intentions to seek infertility care in Lake Zone, Tanzania? So going back to basics, we really found, not surprisingly, that limited reproductive health knowledge limits people's intentions to seek medical care for infertility. Many of us know here that beliefs that contraceptive use cause infertility, past abortions cause infertility, and early sexual debut all cause infertility. And there was the belief that they're irreversible, which makes seeking medical care futile. Why would you go seek medical care if you think what you had done in the past, these are all women's behaviors, is irreversible? That would be futile and not worthy of your time. There's also the belief that women cause infertility and not men. So a midwife from Mwanza said they believe that a man with erectile dysfunction is the one who is infertile, but a man who can have sex is not. Also, a lot of beliefs that infertility is a curse and that, or voodoo, essentially punishment for past behaviors, mostly punishment on women for their own sexual past behaviors. So given this lack of knowledge about the infertility causes, traditional healers were often replace medical providers. A physician from Shinyanga said, many people believe that infertility is only treated by traditional healers. This is why women are so prevalent in prayer meetings seeking help. A midwife from Mwanza said, most of the people that I know don't do anything. They drink herbs and others get divorced and keep getting married to different men. And a nurse from Mwanza said, my patients have miscarriages, but instead of finding out what could be wrong, they believe that they have been witched. So they miscarry many pregnancies, even 6. Again, just highlighting the consequences of infertility and potential for care seeking to possibly remedy and reduce this burden of infertility. And not surprisingly, I see there's some gender norms researchers in the room, but inequitable gender norms that blame women put the care seeking onus only on them. So a man from a focus group from Shinyanga said, the blame always falls on the woman. You'll find the man's family blaming and insulting the woman for no reason, not knowing that the problem could be with him. And for the most part, we men, we don't go to the hospital for tests. A gynecologist said that among those undergoing fertility or infertility investigations to determine the issue, 90% are women and only 10% are men. And lastly, I think this quote really summarizes what I'm trying to get at. A gynecologist from Mwanza said, by the time infertility is discovered in a man, it is likely that 2 or 3 marriages have already broken down. And let's just sit with that for a minute. If 2 or 3 marriages break down because of infertility and it's preventable and potentially treatable, and we can understand the diagnosis, we should be working on this issue to prevent marriages from breaking down and lives falling apart. So inequitable gender norms also limited men's agency that they themselves discussed much more than the women. They didn't have any agency to seek care. They didn't, because of masculine gender norms, because that women were supposed, the expectation was that women would seek care. they were not participating in care and it wasn't their place, but they really felt oftentimes that they didn't have a voice, that they couldn't, and that these masculine norms prevented them from doing so. Men in the focus groups expressed fears that if they had infertility troubles, their wives might go and have a baby with another man while I raised the children. So they wouldn't know if they were the father or not, and that women were really the ones kind of fixing this issue without them being a part of it. And women corroborated this belief, but shared examples of when a man asked his wife to get pregnant by someone else to preserve his honor. So obviously, these masculine norms and norms around preserving honor and not discussing infertility are major barriers to seeking care, and something we hope to change. So how do we tackle this? How do we deal with these entrenched norms, but also really basic lack of knowledge that is a barrier to even wanting to seek care? And I should say, which I haven't said because of lack of time and is in the paper, that people's perceptions were generally that basic services were available. There really was almost no instances. I'm trying to think if I can even think of one that people said, one person did say IVF is, you can't get infertility treatment, it's too expensive. But the perception was that you can get tests, at least in the city. And so really the barriers were much less around cost and access to services and much more around not feeling like men had the agency to do so, or that women thought that was the right step for them to take. So what do we do to improve and to increase seeking medical care for infertility? So just some ideas based on our on this research is to start at the beginning. Knowledge isn't everything, but it's part of the picture. And so we need to improve knowledge about infertility causes and available diagnostic testing and where that's available and what that diagnostic testing can show, including that 50% of the causes are men. So that would require semen analysis. We also need to take a gender normative approach. Obviously, this issue is very gendered and gender norms are a huge part of it. So we need to include men. And what I found surprising in this research was that, maybe not surprising, because we've said this in contraceptive research in the past, but that men felt left out and that they wanted to be a part of, they didn't feel like they had a voice and felt that they couldn't be a part of it. And then lastly, of course, we need person-centered messaging and care, and maybe think about how we can integrate traditional healers into sexual and reproductive health care. So it doesn't have to be mutually exclusive, that you go see a medical provider and you can't seek some traditional healing care. If that's the community provider that you trust, there could be some integration and thinking about, obviously taking a person-centered approach and human-centered design to think about how traditional care could be complementary to medical care is something we can think about. Thank you. I want to thank my team from Health for a Prosperous Nation, or HPON. They're based in Dar es Salaam, and they were wonderful to work with. And my mentor, Jenny Liu. This was funded by the UC Berkeley Population Center and the UCSF Hellman Fellowship. Thank you.
Thank you. Any one burning question for Erica, or shall we save them? Okay. I now have the pleasure of introducing Dr. Jean-Christophe Fotso, the founder and executive director of EVIDAF, a research and development organization which serves the West and Central Africa region with headquarters in Cameroon. Dr. Fotso has over 25 years experience in research, monitoring, evaluation, and learning with subject areas including family planning and reproductive health, maternal, newborn, and child health and nutrition, social norms and gender equity, human resources for health, and health systems strengthening. He's got a full basket. JC is also adjunct professor at the School of Global Public Health at University of North Carolina in Chapel Hill. JC. Sure.
Good afternoon, everybody. It is a privilege to be part of this panel and to share the insight from a study we conducted in Cameroon on infertility, gender norms, and influencers. Let me take a moment to acknowledge our co-authors. I'm hoping you can read. Lotus is one of them. Next, please. This study was part of a larger, broader USAID funded, so now terminated, global project. So I listed here our partners. UC San Diego, represented here by Rebecca, and other folks were the lead. You can see Makere also and Evida, which I represent. Next, to understand the rationale of this study, let's first look at the context of infertility in Cameroon. You'll see overlap, not surprising, with what we heard from Uganda and from Tanzania. Next. In Cameroon, primary fertility ranges between 3 and 7%. And the secondary infertility is between 19 and 26%. So we are within the 1 in 6 that we mentioned earlier. So these figures are consistent with the numbers we understand from other places. So Cameroon was one of the early leader, I would say, in service provision for infertility in West and Central Africa. But the service that were provided have been and continue to be very limited. Access is very limited, and they are also very costly. And this gap has been forcing many individuals and couples to often resort to traditional practitioners. I think a story we heard in Tanzania and also in Uganda. And you can imagine that this is compounded by the persistent stigma associated with infertility. Again, don't need to expand because we heard a similar result. So given these structural barriers, a social intervention is really critical to address this issue. And yet, we found little to no evidence on a study in Cameroon that will seek to address this problem. So next, our study asks, what are the individual, community, social, and systematic factors in Cameroon that influence women's and men's reproductive agency and SRH behaviors? That was the overarching question. In answering this, we sought to, one, understand how people perceive infertility, a bit of overlap with Uganda, investigate how related stigma influence other SRH and health outcome, and finally, explore how gender and infertility-related social norms, here we again, influence the reproductive agency of individual and couple. And this was to ultimately design and test an intervention. Next. Next. So I'll go on this very quickly. This was a formative research conducted, from July to October 2023, about 2 years ago, in a rural site of Cameroon. For those who know Cameroon, in the Middle Belt, northern part, Gangha is the name, and an urban site, Yaoundé, the capital city. A bit like you guys, urban, rural, because those things, again, these are some of the determinants. We use in-depth interviews and focus group discussion segmented by gender, site, and contraceptive profile. We also use key informant interviews, and you'll see soon, to really understand, some of the how the stigma were reinforced or disrupted. We applied a thematic approach using both inductive and deductive coding. Next, population study. So in-depth interviews were conducted with women and men who had experienced infertility, primary or secondary. Focus group were conducted with the broader men and women who are part of a reference group deemed to be influential in upholding the norms around infertility and infertility-related stigma. So they didn't need to be, to have experienced infertility. And finally, we conducted key informal interview with service providers, community health workers, and non-biomedical healers and herbalists. Why? Because these are some of the source of advice and care, as we heard also here. Next. This study yield broad results, but today I will focus on 4 key findings. Next. Our first finding centers on how infertility is defined socially before it is characterized medically. I think we have heard it before. Therefore, becoming an identity shaped by community perception. I think Lotus also mentioned that in our introduction. It's even social before it becomes medical. So our findings reveal how infertility and fears of infertility shape social identity. For example, it is seen as a failure to perform duty and an expected role as a woman, as a newly married woman. In Tanzania, you said you can be sent home. So that's what it is about here. And ultimately, it jeopardizes the sense of belonging. Am I even a woman or a man, for that matter? So this is evident in the use of moral languages, punishment and curse, rather than, let go and seek care. Next. Sorry, go back a bit. So yes, an IDEA participant in the rural site lamented. You can read. When you don't have children, everyone talks about you. Even your partner, sometimes you don't understand his mentality. He turns against you. We heard about some marriages being broken before it is reconciled. So next. So once this social label is applied, the consequences are severe and profoundly gendered. Our second finding is then that when identity is compromised, it shapes emotional well-being, relationships, and mental health through stigma and gendered expectations. We heard it before. Women bear disproportionately more blame. They bear more shame and embarrassment, which in turn erodes their confidence in social spaces and among their peers. The pressure is tied to the belief that every woman's dream is to give a birth. And that's why you mentioned about the right not to have a child. But here it's not really that the case. And some are even praying just to test the pain of childbirth. So again, men also express some challenges, but these were more tied to their masculinity, which can manifest, unfortunately, negatively as frustration, conflict, or even instances of intimate partner violence. Even yet, they are the cause. Next. The reason for this acute and gender distress is the powerful system of pervasive social norms. Our third finding examines who enforces these roles and what those norms are. Social norms and gender are pervasive. They are enforced by a wide range of individuals, including partners, mothers-in-law, parents, religious leaders, medical doctors, extended family members, and traditional healers. Traditional healers largely in rural areas. This norm includes expectation to prove one's fertility and the responsibility of fertility, where women are held responsible when a couple cannot conceive. Next. Now, when these norms are enforced, the result is a sort of community judgment. So our fourth finding details how families and community enforce stigma, often resulting in isolation and social withdrawal. Stigma around infertility or even being remotely perceived as struggling with infertility is common. Women will face public discourse and even gossip, and women's behavior as the cause of infertility. Again, no test has been done. And as a result of this stigma, couples feel exposed. Some then become socially isolated from community and from peers. Next, this FGD woman echoes this sentiment when she said, what will the neighbor say? These people have been married for 5 years and they don't have any children. What exactly do they even do as a couple? You can really see how childbirth is really very much tied to the couple. Next. So here are the 4 findings. So while this finding paint a challenging picture for women and men, we want to examine the opportunity for action. A bit like you, where you are exploring what can be done to really support women, men, and couple. Next. Our study shows that in urban areas, which is the capital city, Yaoundé, doctors and partners are the primary initial source of advice. In rural setting, traditional healers and older women are vital confident because they are thought to be able to blend the tradition with emotional care, which is something we don't get at the typical facility. Family members, especially same-gender relatives, were also reported to be trusted guide. And it is crucial here to recognize the dual role of mothers-in-law. So our studies show that they can be against, but they can also be mobilized as unexpected allies, because typically they are the one pushing for this. So next. A few insights here, I will skip this, just illustrating the point I've mentioned here. So next slide. Our final discussion detailed the strategies and the channels that you can use to address using the asset I mentioned earlier and the channel to reach the group. So multiple channels emerge, as you can see on the left on the screen, that could be used to address infertility through a social determinant lens. And this will be to conduct a number of activities identified on the right. One, mobilize peer network, sort of normalize open dialogue around infertility. It should be taboo. It should be like, I have malaria. Shift social expectation, right? So we should probably, around those discussions, help redefine what it means to be a woman, what it means to be a man. Not necessarily that it should be tied to bearing a child. Mobilize peer network, empower traditional faith leaders, which we understand are the primary source in rural area. All this to build a context where men and women and couple can find resources and help the community to dispel some of this myth. So in closing, I will say that we need to act on the imperative to reframe infertility using some of the findings that you have here in Cameroon and also, in other countries. Thank you for your attention.
Thank you very much, JC. Any burning questions for JC? Okay. I now have the pleasure of introducing Marta Bornstein, who is an assistant professor in health promotion, education, and behavior at the University of South Carolina. Marta is a mixed methods researcher focused on sexual and reproductive health experiences across the life course, including topics related to sexuality and gender, fertility, infertility, contraceptive use, and abortion. She examines how the social construction of fertility and infertility impacts how people with different identities and in various contexts make decisions about and experience reproduction. Marta incorporates a reproductive justice framework to understand how individual experiences and health outcomes are shaped by structural and social inequalities. Welcome, Marta.
Thank you so much. As Loda said, my name is Marta Bornstein, and I'm very happy to be on this panel today. It's been great to hear from all of you. I started my work in infertility in Malawi, and so much of this resonates. And I've was so interested in how infertility was experienced and socially constructed, and I thought, what better place to understand that was within sexual and gender minorities and queer people. So today I'll be talking about the social construction of infertility and how individual and structural conceptions of infertility influence people's lives and the services they access to build their families. So first, I just want to ask, has anyone heard of this concept, social infertility? A few, okay. So its definition has some clear differences from what we've heard before. So social infertility, it applies to single individuals and LGBTQ couples, among others, who wish to conceive biological children. They're considered socially infertile due to their relationship status. And something really important to note is when we talk about, 1 in 6 people experience infertility, social infertility is completely excluded from that. But recently, the American Society for Reproductive Medicine, or ASRM, has updated their guidance on the definition of infertility, but this has not been widely adopted in the US or otherwise. So the main differences you'll see here is it's the need for medical intervention for anyone who is unable to achieve pregnancy with or without a partner. And then this caveat to the definition, which ASRM includes, that nothing in the definition should be used to deny or delay treatment to individuals. But again, this has not been widely adopted by really anyone in practice, and certainly not insurance companies. And I will highlight there's immense inequities in access to treatment. And because this is such an international, interdisciplinary conference, I wanted to make sure to point out that the high costs of infertility treatment are even more insurmountable in low and middle income countries. But even in the US, there's just vast disparities in who can access treatment. And for sexual and gender minorities, this is even more difficult because even if you might have coverage for infertility treatment, it is dependent on you meeting a medical definition of infertility, so unprotected sex for at least 12 months. And someone in a same-sex relationship is likely not going to be able to meet that definition. Excuse me. So today, as others have said, we're talking about the part of reproductive justice around the right to have a child. And there are so many barriers that sexual and gender minorities experience, not only social infertility and access to treatment, but also stigma, structural inequality. Legal protections are really limited across the world and across different states as well. So I'll briefly just go over the methods of the study and some of the key research questions that we had. They're both focused, I'm going to be talking about 2 different studies actually, integrating the results, but they're both focused on how LGBTQ people define and experience infertility within the context of their sexuality, gender identity, and relationship, as well as this question of social construction. So how do people in bodies that may be theoretically capable of pregnancy view and experience infertility itself, but also treatment? And I'm going to probably use the word sexual and gender minority or queer to refer to this population broadly, but when I share quotations, they'll have everyone's specific identities. So like I said, there are 2 studies, very similar goals. The first was the QRAD study, and it was focused more on understanding how people defined infertility and their preferences around family building. And then we have the Sprout study that's currently ongoing. These are kind of like hot off the press findings. And it's focused on people who are considering infertility treatment to build their families or who are currently seeking treatment to understand their perspectives. And I'll just note, I don't think I have this on here anywhere. For both studies, participants identified in a lot of different ways, but they all have a uterus. So that was a criterion for inclusion. Everyone has a uterus. But our study population was extremely diverse, which you can see here. So people had a lot of really interesting identities. Most people in both studies identified with more than one gender identity, more than one sexual orientation. If anything, please let this point you to the fact that these questions on surveys should always be check all that apply. Like I said, for the Sprout study, data collection is ongoing. And I just, people are so beautiful and complex and hard to research. So I feel like this is proof. Okay, so there's many things I want to share with you. Some publications have been out, some are forthcoming, depending on how you define forthcoming. I stole that joke from someone, I don't know who. So first I want to talk about defining infertility, which is a complex thing for queer people, and then paths to family building, which are diverse and also constrained. So participants defined infertility as something that they experienced at the intersection of their identity and their physiology, as well as the context of their relationship in their lives. So this particular participant highlights how context really matters in defining infertility among queer people. She says, oh no, I can't read it. Okay. Technically, certain bodies can't exactly create children together. I guess that might be the technical definition of fertility because they're both still able to have a child, just not with each other. I don't know where to categorize that. Technically, they're infertile since they can't have kids. She goes on to say, people who would otherwise maybe have kids with a different type of partner but can't with someone they're attracted to, they have to go through the same process as a straight infertile couple. And I think that's worth noting. Many participants contrasted their experience and definition of infertility with a medical definition, and they felt that their expansive identities as queer people were in opposition to how others understood infertility. This person says, the medical definition, well, it's the medical model, right? It's always, framed as a problem or an issue that has to be fixed, or basically like, this is broken, you're broken. And he goes on to say, I think so much for our community, we try to push back against those narratives of you're broken and you're wrong and this is bad. And there's a disconnect there when it comes to talking about infertility in our community. There's not infertility just based on disorder or syndrome or anything like that, but infertility based on how your body is currently operating. This was a trans participant, and he also talked about this in the context of testosterone and gender-affirming care. This is a quite similar quote. A participant talked about, how the medical definition of infertility, it's about, the egg, incubated, the human body. And then they go on to talk about a friend of theirs who is male presenting, but has female organs. And this participant was talking to their friend and their friend said, I have female organs, those organs, they can make something, but I view myself as infertile because that's never going to happen. And so it's kind of like using those terms, infertility, to remove the possibility socially of anybody looking at you like that, especially when so much of the idea or concept of gender is around who can make a baby and who can't. So I'll go over this more at the end. The main takeaway just from this section is to emphasize that participants, saw infertility as quite expansive. It was not only reproductive capacity. So now I'm going to talk a little bit about people's understanding and experiences of their bodies and identities and how that influenced their paths to parenthood or family building. So just a note on terminology, assisted reproductive technology I'm using kind of as an umbrella term. We can talk all about the different kinds at some point if you'd like, but just to know that many of our participants used this umbrella term. Participants who are currently seeking treatment were often more specific, but not always. So participants wanted to align their family building goals with their values, and they often saw their values as inherently queer. And it fits well into the reproductive justice and the queer reproductive justice frameworks as well. So many participants spoke about how Infertility treatment, specifically using a known sperm donor, could expand their chosen family. And this concept of chosen family, although it's been widely adopted, is a queer concept that was developed from resistance and exclusion. This person, well, I'm going to read the second quote. So this person said, insemination is sometimes the most ethical. I don't know, that's complicated. A big part of this is the idea of helping create more chosen family. How beautiful would that be to have this person as part of our chosen family? And along those same lines, a lot of participants talked about family building in terms of community care or caring for people in their community, which was a really resonant value for people who have also faced ridicule and exclusion. So this second quote, I think queerness informs that because we're used to knowing what it's like to not feel accepted or to feel like outside of a family, and we don't want other kids to feel like that too. Our participants really grappled with biological relatedness when they wanted to build their families. And while most of our participants did want biologically related children, they were very uncomfortable with that desire. So for example, I found this quotation to be really powerful. It's the title of a paper that I hope comes out soon. And I'll read it as soon as I'm glad that queer people have the option and have more options, but at the same time, are we as queer people not the pioneers of found family? How could we not accept someone who is technically not biologically related to us, but is still part of our family? I think there's constant pervasive idea that if you adopt, you won't love them as much, and that's not true. This one is similar. This participant questioned, what makes you really want to have someone that's genetically related? They asked that kind of rhetorically. They wanted other people to be asking that question because they felt like it wasn't interrogated enough. Interestingly, we also found that participants at times kind of resented the fact that having children would be so much more difficult for them. And the idea of kind of approximating a heteronormative conception was really prominent. So I think you guys might love this quote because we spend so much time talking about preventing unintended pregnancy. And this participant says, it's not going to be easy as oops, I'm pregnant, like some of my friends have experienced. My partner and I have talked about that. Oh, wouldn't it be nice if we accidentally got pregnant and just have a child like that? Like 50% of births. It's not going to happen, unfortunately. We have to do things the difficult way. And another way that people kind of wanted to mimic this heterosexual normative experience was through something called reciprocal IVF. And it came out quite a lot. Participants idealized reciprocal IVF, where one partner contributed an egg and having that biological link, and the other partner carried the pregnancy, ensuring a physical link. And it was really important to a lot of people. And participants had ideas about what they wanted, but they also knew that they would encounter many challenges to having families. This person, it just really highlights how they're thinking about discrimination every step of the way. They have to think about, are they accepting of queer people, whether they're going with a surrogate, which very few people were interested in doing, IVF, a different procedure, the providers. There's always a third party involved for queer people to build their families. I'm going to skip this quote for time. Ultimately, participants struggled to find good options to build their family where they could be fully embraced and accepted. But participants really valued that they had choices. And this is, our participants were so smart and so reflective. And, this person says, I don't think there's anything wrong with any ways of becoming a parent. I think if you want to have kids, however you choose to go about it, any options are good options. People really, really were so, they just emphasized how important options were. And this person explicitly, it's wrapped into reproductive rights, autonomy, bodily autonomy, and trans right. This was a very intersectional issue for people. So to close, I want to again emphasize that infertility is expansive and conceptual and contextual. Queer people had expansive views of family, but many still wanted biological children and a life that they saw as normative. It's important for me to note that most people, regardless of their gender or sexuality, do desire biological children, and our participants were not different. Finally, queer people deserve access to family building options. They deserve to parent their children in safe and supportive environments, and that's increasingly threatened, not only in the US, but around the world. And I hope you can see how much of what I shared today may translate to different populations and in different contexts. And I'm very happy to talk about that in the future. So thank you to my research partners, and thank you.
Thank you, Marta. All right. What a fascinating group of presentations we just had a chance to listen to. I'm going to open it up for questions now. So please go ahead, raise your hand and just call out your question when it's time from the audience. I see one right here. And panelists, if you can turn on your mics, there should be a switch on the body of the mics for you to be able to be heard. Go ahead. Please. Thank you. Let's take a couple more questions and then you guys can decide amongst yourselves what you would like to respond to. I saw one over here. Go ahead.
Thank you, firstly, for talking about this. So important. I did research, particularly with men in Malawi, looking at conceptions of fertility. And I think one of the particular things that really stood out to me was the ways in which it challenged men's sense of masculinity, in terms of hegemonic masculinity, the inability to have a child was such a challenge in the sense of being able to be a powerful man. I think that's as we think about these challenges. I just wanted to ask a question about how we take this to the next level. So we did a policy analysis looking at SRHR generally. It's a huge black hole in fertility in terms of global SRH policy. It's slightly better for women, but it's not a competition, but it's still pretty bad for everyone. So how can we raise this further on the agenda? I'd love people's thoughts around kind of how we get this kind of conversation clearly, not in a small side of it. It's great if it is.
Thanks, Tim. Does anyone have one more question before I pass it to the panelists in the back?
Rape, violence, and other form of threat, behavioral violence, numbers as the consequences.
Thank you. All right, go ahead.
I think I will first answer question 1 and 2. They're sort of related, and I'll let my colleagues add to my voice. This is an important discussion, rarely put out publicly, or even there is some sort of stigma around it, not only among the people experiencing it, but even in the scientific community. We are having difficulties coming out to talk about infertility boldly, have policy shifts around it, and programmatic shifts as well. So I think this is a call to action for all of us in the room, to boldly move towards solving these all things around infertility, ranging from definition to consequences to probable fertility at a later time. And we need concerted efforts across programmers and policymakers. Okay.
Thanks for these questions. They're great, and especially the pronatalist one is a difficult one, but an important one and a really timely one that I get. That is actually, I'd say half the time when I'm working on infertility, that's the response I get, is like, oh, well, now you're fitting in, you're aligning with the, the US right. This is perfect timing. I'm trying to work on infertility for years. So I think it's important to frame our work as we all did today, and that this is a part of this is part of our reproductive rights to have children, even in a higher fertility setting. And so we definitely have a lot of work to do in general on infertility, since it's completely neglected, but thinking about messaging and how we get across that this is part of people's human rights to have a child, rather than aligning with the right or this pronatalist movement. And then just to respond to your question about the next, how to bring this to the broader agenda, I've been speaking with a lot of, obviously we all care about infertility in supporting women and their well-being and their reproductive rights. But I think that potentially a good first step might be, so given that there's very little funding and energy around infertility, is to align with where there is funding energy and to try to convince them. So for example, I'm doing a study in Kenya looking at people with HIV and how HIV negatively impacts fecundity, but adhering to your antiretroviral therapy improves your fecundity. So while my goal as a researcher is to help women reach their reproductive goals, HIV funders were interested in improving ART adherence. That's an example. Another thing is with chronic conditions. So people living with chronic conditions have reduced fecundity, but if they adhere to their medications or choose healthier, change their lifestyle, their fecundity improves. So I've found that appealing to people who may care more about HIV and medication adherence or chronic conditions, but I still have the work that I want to do, which is improve reproductive, might be a good starting point until we can get the message out that infertility in itself is an important enough topic just to fund.
Thank you. I will go to the third question by our colleague. I think our studies, but I will speak for the one in Cameroon, indeed reported a great deal of mental health and violence, first and foremost for women, from partners, from family members, because they view their job as to have a child once they were married. So the experience, I even have some citation where this resulted into some form of partner violence. Men also face challenges, but largely related to their status, but in terms of physical violence, mental health, I think women were more exposed by a wide range of people.
I'm not sure I have anything to add. I agree, and from other experiences studying infertility in different contexts, everything you said was very resonant.
Yes, I think I have something to add. The last presenter, I loved the last point. One of her last points was we need to understand infertility with perspectives of people's desires, goals, and context, if I may add on to mine, because we are defining infertility to measure its standard, but the contexts are not standard. Different values, different cultures are driving the stigma around infertility. So we ought to define infertility better, have a framework within which we can call someone infertile, including the cultural perspective in that framework. And then once we start from there, we can move to the risk factors, see how to help the people facing it, and then give them hope for probable fertility at a later time. Thank you.
Thank you, everyone. We are at time for this panel. So if I may, I'm going to ask everyone to join me in thanking our presenters, but I'm also